Good morning, everyone. We apologize for a late start. We just had a little technical difficulty, but we're all set now. So my name is Tracy Dolan, and I'm the Acting Commissioner of Health for Vermont. Nice to meet all of you. I'm not actually meeting all of you right now, but we can pretend I am in this way. So this morning we're going to be talking about breast cancer screening and recommendations and guidelines around that. Just briefly, in terms of screening rates in Vermont, Vermont has an 82% breast cancer screening rate, which is actually higher than the US rate, which is 79%. The United States Prevention Services Task Force screening recommendations are for mammograms every 2 years for women aged 50 through 74. And at the Department of Health, we recognize that there are a variety of recommendations out there, especially more recently with some of the newer science and newer analysis around screening and its benefits. And we recognize that because there are a variety of recommendations, it can be sometimes confusing to the public and to patients. So today we just want to present some information about screening, and some of that information might reflect some divergent opinions about the specifics of screening. I think the important thing to remember is that we want people to pay attention to breast cancer screening. It's an important thing, and it's important to speak to your medical provider and understand your risk and establish what screening schedules are best for you. And so you will hear a variety of people this morning. I'm just going to briefly introduce them. Our first speaker will be Dr. Donald Weaver. He's a professor of pathology and laboratory medicine at UVM, and he's also the director, at UVM, yes, and he's the director of surgical pathology and the Surgical Pathology Fellowship Program, so at UVM in Fletcher Island. We'll also hear from Dr. Littenberg, and he is also a professor of medicine and professor of nursing. At UVM, we'll hear from Dr. Wood, professor of medicine and director of the Familial Cancer Program at the Vermont Cancer Center and at UVM in Fletcher Island Healthcare. And finally, we'll hear from Dr. Sally Herschorn, an associate professor of radiology and the director of the Division of Breast Imaging at Fletcher Island Healthcare. So please join me in welcoming our speakers today. And we look forward to a few questions at the end of the session. This is your great thing right there.
Okay, thanks, Tracy. Okay, that's great. There's one other hat I wear, and I wanted to let you know, in that I am a co-investigator, primary investigator with Dr. Brian Sprague, who's sitting in the audience, for the Vermont Mammography Registry, which many of you know, also known as the Vermont Breast Cancer Surveillance System. And my task today was to sort of just show you quickly how tumor biology can impact screening. So that was the task that I was given. And this is kind of the old paradigm from the 1970s, and that was that breast cancer was pretty much a single disease. There was a non-invasive form, which was called ductal carcinoma in situ, and an invasive form, which is what most of you would think of as breast cancer. There was a few aggressive subtypes, and there were a few favorable subtypes. The treatments could be standardized. That was the approach that we were using in the cooperative groups for the clinical trials at the time, and that improvements in outcome would be primarily based on earlier detection of breast cancers. Now, in the new paradigms, we recognize that breast cancer is a group of related but unique cancers. They're not all the same, and that the best treatment for any particular breast cancer is determined by the biology of the tumor, which generally can be assessed by understanding its hormone receptor status, estrogen and progesterone receptor, its HER2 receptor status, and some molecular tests that can fine-tune that for us. And then, of course, our fallback, we still need to know extent of disease, which is the stage. How big is the tumor and how far has it spread in the body at the time of detection? This is complex, and it's only meant to sort of show you the concept. I'm not going to explain it, but this is how we have done in the past, or many investigators have done, gene expression profile analysis and learned that there are these approximately 5 families of breast cancer, and that there are 3 major treatment groups that we use to sort of think about how we're going to treat cancer. And if you break those down, they look like this, and I've arranged them with the top being the poorest prognosis and the most aggressive, and the bottom being the best prognosis and the least aggressive. And they are the basal-like cancers, the HER2-positive cancers. The middle one is probably an anomaly of testing and not really a type of cancer. And then there's luminal Bs and luminal As, which we think of as the hormone receptor-positive cancers. So basal-like carcinomas, they're particularly high grade and they have high proliferation rates. And you can see some of the other associations there. Young African-American women, younger women associated with BRCA1 carriers, things like that. And we call them triple negatives because they tend to be, or are, estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. Then we have a HER2 positive tumor, also high grade, also high proliferation rates, and they are generally estrogen receptor negative, or they have only low expression of estrogen receptor. And then we have luminal B cancers, which can have variable grades. They have higher proliferations than the luminal A's, but they are certainly not as highly proliferative as the basal phenotype and the HER2 positive tumors. They are generally ER positive. Sometimes they can be ER low, and they can have variable expression of progesterone receptor. And HER2 can be variably expressed, not expressed generally in a what we would call clinically positive way, but to lesser degrees. And then luminal A is usually low grade. It has a low proliferation rate. It has strong estrogen receptor positivity, and it's one of the most common forms of breast cancer that we see. And typically it's associated with women who are postmenopausal and who develop breast cancer. So what's the effect then of this biology, particularly the growth rate and the aggressiveness, on our ability to detect breast cancer? And I have really one slide to show this. And what I have is this little arrow going to work? Yeah, it's great. Okay, so right here what I've drawn is I've drawn a curve of the growth rate of an aggressive cancer, so something like the HER2 positive cancers or the basal phenotype triple negative cancers. And then I've drawn another curve right here, which is sort of the average of the estrogen receptor positive tumors, or the more indolent tumors, less aggressive tumors that are hormone receptor positive. And then I've put on top of that a mammogram screening interval. And you can decide whether, and we'll talk about more, whether that's going to be 1 year or 2 years, but it doesn't matter. This is a regular screening interval. And you can see here that I've also superimposed on here the average size of the tumor that you pick it up from clinical examination, which is 2 centimeters, and then the average size of the tumor that is picked up by mammography, which is 1.5 centimeters. And you can see that going along here, that there's a tumor present, and it's undetectable, so this is known as lead time. And this mammogram, we don't find it. This mammogram, we don't find it. This mammogram right here, you still don't find it. And then notice that between this mammogram and this mammogram, the aggressive tumor crosses the threshold from both, sort of average mammographic detection and average clinical detection. So this would be known as an interval cancer. And this is the reason why we say that not all breast cancers are detectable by mammography or will be detectable by routine screening, because some can grow at a rate that they are going to develop and be recognized in between the normal mammogram interval. Does that make sense to everybody? So we can simply miss them by the timing. Now, the next thing I did is I put onto this, all I did was frame shift the timing of the mammogram. So for some reason, this woman started, her cycle of regular mammograms maybe 6 months later than the woman on the previous frame. And you can see that by this third mammogram, in fact, even the aggressive cancer is now picked up in between its average mammographic detection and its average clinical detection. So simply by chance, some of these aggressive cancers can be picked up very early because of the timing of the mammogram. So that's how that can happen. And then I've also put on here for you the sort of technical limit to where we can detect tumors by mammogram, which is about 3 to 5 millimeters, and that depends on a number of factors. Even though the median is 1.5 centimeters, the technical limit is around 3 to 5 millimeters. So we can pick up very, very small cancers by mammography, and you can see how the growth curves are different here. So the aggressive growth curves are much more difficult to pick up at an early stage simply because they grow fast, whereas the more indolent cancers that have a lower growth rate, that we have many, many opportunities to pick them up before they're very large. So these are the tumors that are more likely to be picked up by screening, and why we have the controversy because screening is best suited for picking up the low-grade, less aggressive cancers. And that's where the controversy comes in. Now, there are some other things that can impact whether we detect them. And I don't want to make that the focus of the talk because really the growth rate is, I think, the big thing that factors in to the discussions about screening recommendations. But there is tumors develop fibrosis, which is basically collagen or stroma. And if they develop that fibrosis, it makes it much easier to see them on mammogram, and that's what we rely on. And HER2 and basal phenotype tumors are less fibrotic, so the aggressive ones are less likely to make this fibrosis, and the estrogen receptor positive ones are more likely to. And then there's a certain type of cancer called a lobular carcinoma, which often sort of invades as single cells and doesn't make a lot of fibrosis. And about 20% of those are difficult to detect by mammography, with 80% being sort of garden variety detection ability. There are tumor-associated calcifications more likely to be seen in ductal carcinoma in situ, the non-invasive form, but DCIS is associated with invasive carcinomas, and some invasive carcinomas also make calcifications, so that can enhance our ability to detect them because calcifications are easy to see. And the fat to fibroglandular ratio of the breast, as a woman ages, her breast becomes more fatty, that can enhance our ability to see tumors too. So those are some of the other factors that impact detection that are associated with the biology of the tumor. And that's basically all I wanted to say. And then I'm going to turn it over to Dr. Littenberg. If I do that. And how do I get to you?
I don't know, Don.
I'm going to look right here.
Yeah.
And you're, which one are you?
Global, the bottom one, almost, yeah.
That one?
There. Hit it. Oh,
There you go.
we're live. Maybe.
Why is it not? You have to...
You have to hit your F.
Which one of
Thanks,
these
Tracy.
is it?
I'm glad you knew that.
I think I know.
There you go. You're up.
We're up.
Why they pay you the big bucks.
Oh, yeah. Thank you, Commissioner.
I've done my piece.
You have. You have. And who says the state isn't supporting healthcare? Okay. Thank you. Thanks for having me. I'm very excited to be here. I have a very different view of the world than Don. And its point of view is everything. Things look the way they look because of your viewpoint, where you're standing when you look at them. So I was asked to talk about the global view. I'm not sure it's quite the word that I would choose, but everything Don said is absolutely true to the best of our knowledge. The biology of tumors is really difficult. Those fast-growing tumors can and probably do, and I'm quite confident they do, grow so fast that there's no way we could ever mammogram people often enough to catch them really small. So there's a fundamental limitation to a screening strategy that way. And it looks like that works out to be about 70% of tumors are picked up on routine mammograms, roughly, using the mammography registry that Don talked about. Let's see. So we know a lot about the benefits of mammographic screening. If you do find the tumor early and take out an aggressive cancer or an invasive cancer of any sort, even the indolent ones, and take it out before it's gotten very large or before it's spread, you can have a wonderful impact on people's lives. The surgery is small, the disability is minimal, and it doesn't go on to metastasize and make the patient miserable and kill them. And that's the whole ball of wax. That's what the whole business is about. However, there's a downside to every screening activity in all of healthcare, including in mammography, and it's important that we keep that in mind because it answers the question, well, why don't we just get a mammogram every week and catch those tumors, that are growing so fast? Well, one is that it's possible that mammograms actually induce some cancers directly because of radiation. It's a small amount of radiation. Nobody knows if this is a real thing or not, but it's at least a theoretical possibility. And by the time you started doing lots and lots and lots of mammograms, it probably would be a major deal. A bigger issue is the false positives of a mammogram, which are pretty common. A sizable chunk of mammograms are read as, there might be something there. We need to do some sort of follow-up. And the follow-up often involves a biopsy. And then the biopsy is at least an expensive, painful, annoying, and frightening procedure. But it might actually be worse. It might result in identification of suspicious cells that might be one of those aggressive tumors, or it might be a really slow-growing tumor, or it might be something that just looks like a tumor and really isn't a breast cancer, at least not in the sense of a cancer that's going to grow up, spread, and hurt you. And it's really hard to tell these apart in spite of the best efforts. Now, we've gotten better with the kinds of tumor biology that Don's describing, but still an awful lot of these biopsies are things like DCIS, where it's not entirely clear what we should do with them, but they do say carcinoma in the title, and it's really hard to say, oh, just let it be. And we wind up doing treatment for them. And some of those women get a benefit from that treatment, but some of them don't. But they all have to take the treatment, you know, the lumpectomy or the radiation or drugs or whatever it is. And that's all got costs, not just financial costs, but personal costs, emotional costs, physical costs, and social costs. And it's not a small amount. There are the false negatives, of course. The people who get their mammograms think that they don't have cancer because the mammogram missed it. Happens 30% of the cancers are missed. And that's a bad thing. And then there's the flat-out costs, the cash costs of getting the mammogram, the money it takes to perform the study, to interpret it. And this is, the technical term is gazillions and gazillions of dollars that are spent on this. So what should we do? Well, this is one of the most well-studied things in all of medicine. Unfortunately, it doesn't entirely come to a clear answer. Looking at it from the biological side, as Don described, you are tempted to do more and more screening because of those rapid growth rates, or to use the biology as markers and use family history. Maria will talk about that, and Sally, and that's all valid and important. When you zoom back and look at the population level and say, let's take thousands of women and screen half of them and not screen the other half and see what happens. Do they live longer? The answer is yes, if they're average risk women between ages 50 and 70. And the studies in that population are remarkably convincing. Mammography saves lives, net, in spite of the problems that I described. And the data are, most of them 2 years is good, 3 years. It's not entirely clear. So every 2 to 3 years in that age group seems perfectly reasonable to me. If you want to do it every year, I wouldn't arm wrestle you over it, but there's really not an awful lot of data supporting that. What if you're younger? Well, those same studies have failed to show us a life-saving advantage in women under age 40. And this is really disappointing because women under age 40 do get cancer. It's probably got something to do with just what Don said, is the younger women tend to get these more aggressive cancers that grow up rapidly between the screens anyway. It just doesn't do it often enough. It doesn't catch enough early ones to really net out as a big benefit at the population level. Again, we're talking about average risk women. So there's on the other hand, everybody wants it to work for young women, and there's some biological reasons and some arguments pro and con on it, but the bottom line is the big population studies have not shown benefits in that area. Well, what if you're older? What about the women over 70 or maybe 75? Not an awful lot of data. There aren't good clinical trials. We don't really know. The good news is the cancers are slower. On the other hand, elderly people with a lot of other medical problems, preventing a disease that's going to kill them 15 years later may not actually be all that important if they're dying of something else. So a lot depends on their health status and intervening issues. And this is a kind of approximately data-free zone, which is not good. Let me talk about some non-average people. Lumps. People with lumps in their breasts are not average risk. Okay? In fact, a mammogram alone is rarely the thing that you need to do in working up. If you can feel a lump in the breast, that is, all that data I just talked about is off. We've got to track down that lump and figure out what it is. So this is about the most common error we see in primary care and in population health. So that's a big deal. High-risk women, extra attention. The data are softer, but if you've got a strong family history, these gene markers, a personal history of some other cancer, probably a more aggressive screening regimen makes sense. It's going to have to be personalized. We ought to get someone who really knows the ins and outs of this corner of healthcare to help you out, someone like Marie Wood, who I hope is next. Thank you. You go here.
Nice segue.
Which one is yours?
That one, the bottom one, the bottom one.
And then we learned that it was function F8, but we did not learn well.
So the commissioner comes in.
And that's where the commissioner
Duplicate?
comes in and presses that button.
Oh, it's 5. How did it become 5? Thank you.
There we go. Okay. So I was asked to speak about breast cancer screening guidelines for women at moderate and high risk. And what I thought I'd do to cover this subject in 5 short minutes is really embrace a little bit more or expand on the risk factor part and how we assess risk, review the options for those people who are at higher risk, and then end by comparing average, moderate, and high-risk guidelines for you. There's a variety of risk factors. We all know that women who take hormone replacement therapy have an increased risk that's slightly above average, 1 to 1.4 relative risk, so just slightly increased. Women who start menstruating early and menstruate longer seem to have more risk. We know that there's some diet component, although we're not really so accurate about that. And alcohol has also been shown to be a factor, but these are small risk factors. The big risk factors happen for women who have very dense breast tissue. It's probably more important that they don't lose their breast density, and that seems to be associated with risk. Women who have a biopsy, like Dr. Weaver was talking about, that show atypia or lobular carcinoma in situ have a high risk of developing breast cancer down the road. And women who have a strong family history or these BRCA1 or BRCA2 or now a number of genes have the highest elevation in risk. Well, how do we break up these groups? We heard a lot about average risk, which is about a 12% lifetime risk. Moderate risk, I really think about as 15 to 20% lifetime risk, and there are a number of models, and I only was given 5 minutes, so I can't even get into those. So women in this group have some family history, but not those dramatic family histories that we see sometimes. The people who have a biopsy showing atypia probably are at that 20% lifetime risk. Women who have a stronger family history with early onset cancer and multiple people with cancer have a higher risk. Younger women who in their younger time period between 10 and 30 have had chest wall radiation therapy, say for Hodgkin's disease, also have a pretty elevated risk for developing breast cancer. And we know that BRCA1 and BRCA2 mutation carriers are at the highest risk, and now there's a number of additional genes. As we've heard a little bit, there's clearly an advantage in overall survival, but maybe more importantly for breast cancer specific survival when we do screening over 50, but there is a false negative rate that you heard a little bit about. For women under 50 in that 40 to 49 range, while their overall survival may not be different, they do have improved breast cancer specific survival, not at the same range, not at the same percent as women over 50, but they have a higher rate of false positive, meaning biopsy, and also false negative, probably because this group has pretty dense breast tissue and it's harder to see through that. That's different than using that as a risk factor. Sometimes we make recommendations for women to start their mammograms under age 40, but it's important to understand that that recommendation is really not of proven benefit, and we know that there's an even higher false negative rate. So what can we do? We can think about screening breast ultrasound and screening breast MRI. Dr. Littenberg has already told you a little bit about how it's important to assess a woman with a breast mass, and ultrasound can really do that. And that's probably, in my opinion, one of the great benefits of ultrasound. It is, as a screening tool, very time intensive, and the quality is dependent on not only the interpreter, but the technician who has to very time intensively screen the entire breast. There is some evidence that shows that you can find increased detection of small cancers when you add this to mammogram, and there is some studies that it benefits women with dense breast tissue and some high-risk populations. Screening breast MRI is now an acceptable tool. Its interpretation is not sensitive to breast density, so it's really good for younger women, and there's no radiation exposure that we heard about with mammogram. For premenopausal women, an MRI needs to be done at a very specific time in the breast when they're very quiet and we don't get a lot of activity and abnormality. Its interpretation is dependent upon volume, so you want to be at a big center where you get your screening breast MRI where they're used to interpreting these, like we are here. It is expensive technology, and some of that is still not always covered. But should be in most cases. There are high biopsy rates, meaning high false positives, and we have to be careful about that. For women who are in these very high risk groups because of their family history, one of the things that when we look at the studies in aggregate, and there are probably more of this, that show that MRI is a very sensitive tool, the important thing to understand is that MRI is not as helpful in these groups. It doesn't have that same benefit that it does for the lower average risk groups, probably because cancer happens more frequently and you need a finer, better look at the breast tissue. We know that when we add screening breast MRI, we not only increase the sensitivity when you add this to mammogram, but we decrease the likelihood of finding a cancer in between screens due to the rapid turnover rate of those cancer cells. And a lot of women who are in these BRCA1 and 2 families have a propensity to develop cancer in between screens if you're just using mammogram. Screening breast MRI can cut that significantly from almost 50% when you're using mammogram alone to less than 10% when you add MRI. So who should be screened with an MRI? It's clearly recommended based on evidence for women who are in BRCA1 or BRCA2 families, or have a first-degree relative with a BRCA1 or 2 mutation, or they have it themselves, or they have a 20% risk, not based on any model you choose, but based on their family history. It's recommended for women who've had radiation therapy, and it should start early. For people who have some of these other genetic abnormalities, such as Li-Fraumeni syndrome or Cowden's syndrome, and we can talk about that later. There is insufficient evidence to screen women with MRI if you have less than a 20% lifetime risk based on your family history, or if you have a biopsy showing atypia, or if you have just dense breast tissue. Insurance may not cover that. So this is a tiny slide, but I think the things that I want for purposes of time to guide you to is I've added average risk here, moderate risk here, high risk here, and BRCA1 mutation carriers or 2 mutation carriers are even higher risk. We don't recommend breast self-exam anymore, but I agree that breast self-awareness and bringing a lump to the attention of your healthcare provider can be important for breast health. I'm not going to focus on clinical breast exams since we didn't talk about those, but those can be a helpful strategy, not because we know it's going to save your life, but it often brings you in front of a healthcare provider for an extensive evaluation. We talked about average risk women, and you can either start at 50 as recommended by the USPSTF. Many of us who are taking care of cancer populations prefer the American Cancer Society recommendations starting at age 40. For women who are at moderate risk, we recommend starting 10 years before the earliest age of diagnosis in their family, or 40, whichever is earlier. For women at high risk, we start mammography at age 30, or 8 to 10 years after they've had chest wall radiation therapy. And for BRCA1 or 2 carriers, we start at age 25. Screening breast ultrasound is not recommended for any groups other than those with dense breast tissue, or maybe women who can't tolerate a screening breast MRI. And as we've talked about, MRI is really only recommended for those groups at highest risk for breast cancer. And I think to hear more about these imaging modalities, we'll hear from Sally Herschorn. And I don't know how to do this. Do you know what to do?
No.
Okay. Let's see if we can. Which one is yours?
This one.
This one
No,
here?
Yeah. And then you do F5. Does that work? No.
We need the commissioner.
Oh.
Thank you, Marie. So I have to disclose that my spouse and I own a small amount of stock in a company that makes mammography equipment, but I also want to tell you that I've been doing screening mammography for 24 years and that I strongly believe in the value of screening mammograms and saving lives. So just so you know where my point of view comes from. The good news, as you've heard, is that the mortality from breast cancer stayed stable for 50 years in this country and then began to decline as we introduced mammography. It has declined about 30% since then due to the combined effects of early detection, increased awareness, and better treatment. So as you've heard, there is evidence of lives saved, and that applies to women 40 to 75 who were in randomized controlled trials. It can be reduced 20 to 30%. And when you do a controlled trial, you invite women to screen and compare them to those who are not invited. And there is a lot of cross-pollination between the two groups. Many people don't show up for their testing. So studies that looked at women who were actually screened have shown an even greater mortality benefit. And you've heard about the recommendation. So as Marie said, we recommend for average women beginning at age 40 and continuing every year as long as the patient remains in good health. This is endorsed by major medical organizations, but you should know that the American Cancer Society is currently in the process of reviewing the research and reviewing their data, and they may in the future change the recommendation. Marie already talked about the high-risk women, so just for time's sake, I won't go into that. It has been suggested by some that we target our screening to women who have a family history or who are at high risk. And the problem with that is none of the scientific studies actually grouped people by level of risk. So if there is no scientific proof that that would work on a population basis. As well, 3/4 of breast cancers are diagnosed in women with no family history. So screening only those with a family history would miss about 75% of breast cancers. And the USPTSF, as you've heard in 2009, revised their recommendations, and some people thought they threw younger women under the bus. But it was widely reported that you shouldn't screen under 50 unless you're high risk. But that's actually incorrect. If you look at what they said no screening under 50 according to the patient's context and values. And by values and context, they meant the personal choice of benefits and harms, and they really gave a lot of emphasis to the potential harms of mammography, which, as Dr. Littenberg went over, are the false positives, the false negative, the radiation, and the overdiagnosis. False positives occur in, on average, about 10% of women. It happens to be similar percentage to the callback rate from pap smears, and we now have a lower callback rate from 3D mammography. But really, when you're called back, you have usually just 1 or 2 additional views or an ultrasound, and the problem is resolved. Only about 20% of the people called back go on to biopsy, and most of these biopsies are benign. Is this anxiety-provoking? You bet you. These women are very, very anxious, and no matter what we do to try to comfort them, they are anxious until they find out that their test is negative. But the good news is that the studies show this anxiety is not long-lasting, and most women are actually very happy that they were called back to do additional testing and make sure that they don't have breast cancer. Make sure that their mammogram was not a false negative. If we had not called them back, it might have been not detected. Now, the most common cause of not detecting a cancer on mammography is dense breasts. And about 50% of the population has dense breasts. Tomosynthesis or 3D mammography can increase the detection rate in dense breasts, along with decreasing the callback rate. And supplementary screening, as Marie talked about, we'll talk about more in a minute. Just to talk about dense breasts, these are the 4 categories of dense breast tissue. And along the bottom, I've put the percentage of population that has each of these categories. And the risk is increased in dense breasts compared with the risk in level 4 is increased compared to level 1. There is no data about level 2 and level 3, which applies to 80% of the population. So you might hear people say, oh, I have dense breasts, I'm at increased risk. Yes, but we don't know exactly how much that's increased. Now, what about supplementary screening? I'm here talking about average risk women. It can find additional breast cancers that weren't detected by mammography that were masked by the dense tissue. There is a higher false positive rate than mammography, especially when you're doing it with ultrasound. So the decision to go on and seek additional screening is an individual one, and you should know that there's no major medical organization that's currently recommending this, although intuitively it might make sense, and there are no randomized trials showing that it saves lives. There are state breast density laws in 19 states currently. It covers over 50% of the population. Vermont is not one of them. This is promoted by a political organization called rudense.org. You can go to their website, and most states' laws require patients to be informed in their lay letters about their breast density, that they have dense breasts, and that they might wish to seek additional screening. Different states cover it differently about whether they mandate coverage. And for the most part, we're talking about ultrasound for patients who want additional screening because they're dense and have low to moderate risk. And for patients who are at high risk and want additional screening, we're talking about MRI. Now, the risk of radiation is a theoretical one, as Dr. Littenberg said. It is probably, if it even exists at all, would be a rate of less than 1 in 100,000. It should not dissuade anyone from screening. You might have heard about the controversy of overdiagnosis. This means that we detect a cancer and that would have not caused death to the patient if we didn't detect it and treat it. It's been controversial lately. There's been a lot of studies saying that the rate of overdiagnosis is high. Many of these studies are very flawed. There is probably very little overdiagnosis of invasive breast cancer unless we're talking about those that are quite old or ill. DCIS, as Dawn mentioned, is something that progresses at a variable rate. They won't all progress. It is something that we mostly diagnose with mammography. We only diagnosed 5% before mammography. Now 25% of breast cancers diagnosed are DCIS. So certainly some of them are overtreated, but my answer to that is we need more research into which ones are going to progress and not dump screening because of that. Now, why am I emphasizing annual? If you look at the data and computer modeling based on that data, if you look at the top arrow, A stands for annual, 40 to 80. This has, based on computer models, has the potential to save 40% of lives if you screen everyone in that age group, versus the other arrow is the USPTSF model of 50 to 74 every 2 years has the potential to save 20 to 25%. Now, why did they single out the group 40 to 49? And you've heard about that before. You've heard that this group is different. Well, I'm here to tell you that this group is not different based on a cutoff of 50. If you look at the graph, this is the rate of breast cancer diagnosis from age 40 to 75. It's a very gradual slope. There is no change in the biology of breast cancer at 50. The breast density doesn't change at 50. 50 is not a marker for menopause. Menopause doesn't change exactly at menopause, the biology of breast cancer, nor does the ability of the mammogram change abruptly at 50. None of these are abrupt changes. If you group the data of 40 to 50 compared to 50 to 75, you will see an abrupt change. But if you look at the data on a gradual curve, this is just a gradual progression with age. And 1/6 of breast cancers are diagnosed in women in their 40s, and more than 40% of life years lost are from women in their 40s. And these women are usually caring for young children, perhaps caring for old aging parents, the economic breadwinners in their families, so it can have potential greater and economic impact. What about the 75 and over? Well, the American Cancer Society recommends that we screen as long as the patient remains in good health. Women 75 to 85 may have 5 to 10 years of useful life. And you should be healthy enough that you would perform surgery or do something if you found a breast cancer. But you should know that there's no other first world country except the US that does this. And that none of the randomized trials included women who are over 75. There are some trials that show that you can diagnose cancers earlier and women can benefit from less aggressive treatment if you screen, but it's not scientifically proven. So in my opinion, the benefits are less for this age group. There certainly could be benefit to certain individuals for less treatment, but we just don't have the proof. What about the harms of not screening? There's been so much said about the harms of screening. Well, obviously, there are harms, as you can see here, of not screening. So I want to leave you with, for you to make the decision. Many primary care physicians go according to the USPTSF guidelines. These guidelines were designed as a balance between the benefits and the perceived harms. And this balance was chosen by a group of individuals who decided according to their values. You need to decide for yourself where that balance is based on your values. We recommend and personally follow the regimen that has the ability to save the most lives. But it's your choice to think about the benefits and harms to you and be proactive about your health. If you want to go to the ABC News website, they have a pledge you can take. The pledge stands for Prevention, Learning, Examination, Density, Genetics, and Educate, so that you can be proactive about your health. because after all, at today's breast cancer conference, it's all about your priorities and your choice. I want to thank you for your attention and let you know that if you have any questions about screening or mammography in general, you can write to us at mammoinfo@vtmednet.org, and we're happy to answer your questions. Thank you.
I was hoping we could stick around for a few more minutes and maybe open up for a few questions. I just wanted to summarize. We heard a lot of great information. We're so fortunate in Vermont to have this kind of expertise and be able to bring it into this kind of forum. But and we heard some divergent opinions, but I also heard some common points, and I just wanted to highlight. Certainly, we heard across the board that mammography saves lives. A regular screening schedule is best. We've heard that level of risk can affect the kind of screening schedule that makes sense for you. And we've heard that the conversation with your medical provider is really important, particularly for women under 50 in determining the right screening schedule for you. And so I wonder if we can open it up to some questions. Okay. I'll do my Oprah. Oprah has people that do this, but.
Actually, a question for you. So if you have BRCA 1 or 2, you're supposed to be having an MRI yearly. How and who can help us fight the insurance companies to help pay the $3,500 a year?
So most of the time, it's true that insurance does cover for BRCA 1 and 2 carriers. We recently have run across some insurance companies who don't realize those recommendations. And I would say that if you're a carrier and you have that issue, then come to our familial cancer program or a breast surgeon, and they can help you get that.
Thank you.
I'm a breast cancer survivor, and I'm curious, should I advocate for a 3D mammogram annually when I get mine?
I guess I'll take that one. The data is not out on 3D mammography. It's fairly new. The preliminary data shows that it has the ability to detect more breast cancers, and also it's the only technology that, while detecting more, can decrease the callback rate. Usually there's no free lunch. Whatever you add will increase the callback rate. This is the first thing we have that can do that. So we certainly believe it can be helpful. It's not the answer to everything. It doesn't prevent all callbacks, and it doesn't prevent missed cancers, but it certainly can be helpful. There's no reason that you shouldn't get it.
So we've got time for about 2 more questions.
I was just curious, are the MRIs usually done in conjunction with the mammogram, or are there populations for whom they should just be getting the MRI?
So currently, the recommendations, you can do them annually. You can get both of your screens at the same time, or you can alternate it and get one technology every 6 months. In Germany, they do not do the mammogram all the time. And for BRCA carriers, we actually recommend starting MRI at 25 and not adding mammogram till 30 or even later. I think the issue is that sometimes MRI misses DCIS, and that is the cancer in a carrier that you want to be able to pick up. So we're not quite far enough along to drop the mammograms, but that might be a reasonable option.
Anyone with a final question? Yes? Okay. You know what? We'll squeeze in 2 more.
Our local hospital has started a form of ultrasound called elastography. It's supposed to work better for women with dense breasts. Can you comment on that? They're advertising it's more sensitive than regular ultrasound.
So elastography is a technique that can help you out potentially when you have found something. It is not a modality for screening at all. If you find a breast mass and you're unsure about whether to biopsy it or not, in my experience, very small amount of cases is it helpful. Really, the majority of criteria about whether to biopsy a mass or not are based on its imaging characteristics, not its elastic properties. It's just supplemental.
And our last question, I think we had a hand up here. Was that you?
Yeah, I'm a survivor also, and I was a triple negative person. I am, I guess I should say. And so what I'm wondering is, because that's a more aggressive form of cancer, is there a necessity to doing something in addition to mammography every year, which is what I'm currently doing? Would it make sense to be doing an MRI as well? I don't know if it would be covered or not, but would that make sense?
Seth, you don't want to take that? I mean,
Currently, we're actually looking at trying to find screening tools for to identify triple negative breast cancers, but it's hard to identify those people as a risk group other than BRCA1 and 2 carriers. There's no evidence that screening you with anything other than mammography and good clinical follow-up is clearly going to be helpful at this time. It is under investigation.
yeah, I think what we know is that we know that any individual woman is a little bit more likely to develop a cancer similar to what she had previously if she develops a second cancer, but it's not a guarantee. So it's just that you're operating on the same risk pattern that developed the first cancer.
Okay. I'd just like to add that there have been quite a few studies now that looked at MRI in patients with prior breast surgery and prior lumpectomies for breast cancer, and the detection rate of second cancers is fairly similar to the MRI screening of the 20% or higher group. So although the American Cancer Society currently doesn't have it on their list of recommendations, it's a plus minus, and hopefully in the future it will be on the list of recommendations.
Okay, well, thank you very much to the speakers, and thank you very much for joining us.